Good evening, everyone. I'd like to invite you to today's webinar as part of the pediatrics series. Our topic for today will be approach to a comatose child. And our presenter is Dr. Lucia Amolo, who is a pediatrician and a pediatric neurologist in training at the Kenyatta National Hospital. My name is Dr. Kailemia. I'll be your moderator for today. You can type in your questions in the Q&A box and we'll answer them at the end of the lecture. Dr. Lucia, you can go ahead and share your screen and start the presentation.
Thank you, Dr. Kailemia. I hope I can be heard clearly.
Yes, you can.
So good evening, everybody. I hope you can all see my slides, Dr. Kailemia.
Yes, we can, Lucia.
All right. So today I will be discussing disorders of consciousness in children and how we approach this. As Dr. Kailemia has said, my name is Dr. Lucia Amolo. So as an introduction, what exactly is consciousness? Consciousness is the state of awareness of self and that of the environment. There are two dimensions to being conscious. You have to be awake and you have to be aware. To be aware, so for you to be aware, you must be awake. But for you to be awake, you don't necessarily need to be aware. So in a normal human being, we exist in two states. We're either awake or asleep. When you're asleep, it's a state of where awareness to the environmental stimuli is reduced. Sleeping persons can be aroused to a normal state of consciousness. And when you're asleep, you're not considered to have a disorder of consciousness. Abnormalities in consciousness can occur in several ways. You can have clouding of consciousness, which is minimal reduction of wakefulness or awareness, wherein the main difficulty is in attention or vigilance. This means that I can be awake, but my attention is slightly reduced. Confusion is the state of impaired ability to think and reason clearly at a developmentally and intellectually appropriate level. Therefore, what this means is that the definition of confusion in a young child is much different from that of an older child. Coma and other impaired states of consciousness warrant a medical emergency. And the focus of my discussion today will be on coma and other impaired states of consciousness. So before we dive into disorders of consciousness, we need to understand what keeps us human beings in a conscious state. So, and that is the pathophysiology of the consciousness state. So consciousness usually requires the brain to be intact. And there are two specific parts of the brain that must be intact, what we call the ascending reticular activating system. This is a projection of neurons that usually run from your brainstem. Your brainstem constitutes your midbrain, your pons, and medulla. These neurons project all the way to your cerebral cortex, and they ensure that you are able to stay in a conscious state. So you must have an ascending reticular activating system that is functional. Your cerebral cortex, which is your brain matter, must be functional, and you must have healthy projection between these two systems. To be in a state of consciousness, you don't just require the reticular activating system and the cerebral cortex to be functioning, but you do receive input from other parts of your brain, such as your cerebellum, your corpus striatum, what we call the diencephalon, which consists of your thalamus, hypothalamus, and epithalamus. We also receive input from your spinal cord through your ascending pathways. Our ascending pathways are our spinothalamic tract, which is responsible for pain and temperature. And we have what we call our dorsal columns, which are responsible for proprioception and joint position. To be in a state of consciousness, you also require sensory input from your optic, auditory, olfactory, and taste. And these projections run to and from the reticular activating system. So the function of the ascending reticular activating system and the cerebral hemispheres, which keep us in a state of consciousness, depend on a number of factors. You need presence of substrate for energy production. For your brain, the brain is a highly metabolic tissue, and for the brain to function, it usually requires glucose as the main substrate. Therefore, for whatever reason, if you're hypoglycemic, then you will lack enough energy and the brain will not be able to function well, and you will have altered state of consciousness. Adequate blood flow is required because blood carries an oxygen to the brain and removes carbon dioxide from the brain, and oxygen is required for ATP production in the brain. Absence of abnormal metabolic wastes or toxins is necessary for you to be in a normal state of consciousness. Examples of abnormal metabolic wastes would be in a patient who has uremic encephalopathy, secondary to maybe chronic kidney disease, and they have buildup of urea, which can cause altered consciousness. You must also have normal body temperature for you to be in a state of consciousness. Extreme hypothermia can alter your consciousness, and hyperthermia can increase the basal metabolic rate of the brain, thereby altering your consciousness. For example, in patients with meningitis. You also require absence of abnormal neuronal excitation. This means that you should not be having continuous seizures, because if you have continuous seizures, you have excessive excitation in your brain, which can alter your state of consciousness. Absence of CNS infections such as meningitis and encephalitis, and you must have a normal intracranial pressure. So the states, so for you, impairment of consciousness states exist in three forms. You can have impairment of consciousness with activated mental state, impairment of consciousness with reduced mental state, and impairment of consciousness along the continuum of coma, vegetative state, minimally conscious state, and related conditions. I will discuss each of these in detail. So, impairment of consciousness with activated mental state. What does this mean? It means that the patient has an active mental state and slight impairment of consciousness. Examples of this, I think most of us have rotated through Madare, and when you rotate through Madare, most of the time you encounter patients who are conscious, who have some slight impairment of their consciousness, but they have an activated mental state. They will present with things like hallucinations, which are perceptions of sensory input that are not present. You can have auditory hallucinations, visual hallucinations, olfactory hallucinations. You can have illusions, which are misinterpretations of actual sensory stimuli. You can be delusional, which is incorrect thoughts or beliefs that do not change when challenged by contradictory evidence or logical reason. For example, many of the patients in Madare believe that they are Christ and they have come to save the world, and you cannot do anything to change these delusional thoughts. Delirium is an activated mental state that may include disorientation, irritability, fearful responses, or sensory misperceptions. You can have impairment of consciousness with reduced mental status. There are three forms. You can be drowsy, obtundation, or stupor. When you're in a state of drowsiness, usually you can be aroused by verbal or light touch. When you're in a state of obtundation, deep touch, such as a deep scan or rub, can arouse you. When you're in a state of stupor, you require vigorous, painful, or noxious stimulus in order to be aroused. Then we have impairment of consciousness with the continuum of coma, vegetative state, and minimally conscious state, which will be the focus of my discussion today. So comatose patients, there are many things that can cause a patient to go into coma, which we will discuss today. So coma is usually in the worst end of the spectrum. Then you can have an unresponsive wakeful syndrome, which is previously referred to as a vegetative state. And then you can move on from a vegetative state to a minimally conscious state. And from the minimally conscious state, you can actually emerge to a confusional state. And when you emerge from this state, majority of the patients will have some sort of disability. It can be severe, moderate disability, and in rare circumstances, you can have a full recovery from a disorder of consciousness. Then you can have locked-in syndrome, which I will discuss in detail, as well as akinetic mutism. So, what does it mean when you encounter a patient and you're told that the patient is comatose? Coma is a state of deep unarousable, sustained pathological unconsciousness, usually with the eyes closed, that results from dysfunction of the ascending reticular activating system, which we've talked about in the brainstem, or in both cerebral hemispheres. Patients in coma lack both wakefulness and awareness. They have an absent sleep-wake cycle. In a normal human being, we go through a normal sleep-wake cycle, meaning during the day, you're awake. At nighttime, you go into sleep, and there are two stages of sleep, what we call rapid eye movement sleep and non-rapid eye movement sleep. During the night, we cycle between this non-rapid eye movement and rapid eye movement sleep, and their characteristic behavioral and EEG patterns that can help identify the stage of sleep that you're in. So in a comatose patient, they lack this normal sleep-wake cycle. So unresponsive wakefulness state or vegetative state. I have a picture there of Michael Schumacher, who's the famous rally driver who sustained a severe head injury. And upon sustaining the severe head injury, he went into a comatose state. He was able to come out of the comatose state, and now he's in a vegetative state. So what is a vegetative state? In this state, you have complete unawareness of self and environment, accompanied by sleep-wake cycle, meaning you're awake and then you go through your REM and non-REM sleep with complete or partial preservation of hypothalamic and brainstem autonomic function. Some of the brainstem autonomic functions are like regulating your breathing, your temperature, and your heart rate. Usually, if you're in a vegetative state, you demonstrate a variety of sounds, emotional expression, body movement, smiling, and shedding tears. I think we've all read reports in the news where the family members report that Michael Schumacher sometimes sheds tears, sometimes smiles. There's a lack of sustained visual fixation or tracking. The clinical course of evolution to a vegetative state usually involves an acute injury. For example, a road traffic accident and you hurt your head, you go into coma, which can last days to weeks, and then you go into the vegetative state where you have appearance of the sleep-wake cycles. And this you'll be able to know by performing your EEG and seeing the characteristic sleep and wake cycle patterns. So the criteria for placing somebody in a vegetative state requires no evidence of awareness of themselves or their environment. They're incapable of interacting with others despite being seemingly awake. There's no evidence of sustained, reproducible, purposeful, or voluntary behavioral responses to visual, auditory, tactile, or noxious stimuli, meaning you can try and talk to them, engage them, but you will not have any purposeful response for them. They have no evidence of language comprehension or expression. They have intermittent wakefulness manifested by the presence of sleep-wake cycles. They have sufficiently preserved brainstem function, autonomic function. They have bladder and bowel incontinence, and they may have cranial nerve pulses, and the spinal reflexes usually be intact. Then you can move from the comatose, the vegetative state, to what we call a minimally conscious state. So in a minimally conscious state, you have severely altered consciousness, which demonstrates minimal evidence of self and environmental awareness. These individuals are not really aware of who they are or where they are. They have a neurological recovery is better than the vegetative or the comatose state, and the life expectancy is longer than that of the vegetative state. Then we have locked-in syndrome. Now, locked-in syndrome occurs when a patient has retained consciousness and cognition, but is unable to move or communicate because of paralysis. These patients have paralysis of all their muscles, with the exception of that of their eye. It usually occurs due to involvement of what we call the corticospinal and the corticobulbar tracts, which we know from our anatomy is responsible for movement. It's quite a rare syndrome in children, and communication is usually by eye movement. So you can, for example, tell the patient, blink twice if you can understand me, and you'll actually find that these patients will usually be able to respond. So their communication usually relies on the eye movement, which is the only muscle that is not paralyzed. We have what we call akinetic mutism. Again, this is a rare condition in children. Pathologically slowed or nearly absent bodily movement accompanied by loss of speech. Wakefulness and self-awareness is preserved. The mental function, however, is reduced. The areas of the brain that are usually damaged include the midbrain, the diencephalon, which includes your thalamus and hypothalamus, and your inferior frontal lobes. Then we have what we call brain death. So brain death is irreversible cessation of all functions of the entire brain, including the brainstem. In Western countries, it's legally accepted as equivalent of death. This, however, is not universally accepted. In most of the sub-Saharan African countries, including Kenya, there are no legal guidelines regarding brain death. Why is this? Barriers to the development of laws exist in Kenya. We know that we have a lot of cultural, ethnical, and religious diversity, which creates quite a complex perspective about death, which challenges the development of uniform guidelines. For many of our cultures, we believe that as long as the patient is breathing, even though they have brainstem death, then culturally we believe that these people are still alive. Clinical diagnosis of brain death requires an irreversible coma with a known cause, elimination of reversible factors. For example, if you have a patient in the pediatric ICU and the patient is sedated on midazolam, you cannot diagnose this patient as having brain death until you eliminate the midazolam. And usually these patients have absence of brainstem function and apnea, which I will discuss in detail. So this is just a summary of the disorders of consciousness that I have discussed, which you'll be able to go through later in detail. So when you have a pediatric patient coming to the pediatric outpatient department and you're the one presented with this patient, how do you approach this patient? What do you do in order to be able to coin the particular diagnosis of this patient? Number one, you need to do a rapid assessment and stabilization. That is your ABCDE approach. Check your airway, make sure it's patent. Look at your breathing, ensure you have adequate oxygenation and ventilation. Check your circulation, make sure that your patient is not in circulatory failure, compensate for this. Then once you're sure that your patient is stable, you can now take a history. And the history you're trying to take is to try and determine the etiology. What has caused this patient to be comatose? Because there are very many things that can cause a patient to be comatose. You then do a physical examination to determine the site of the primary lesion. I've included this picture of the brain just to emphasize that when you're doing your physical examination, you should be able to pinpoint exactly where the lesion is in the brain that is resulting in the patient being comatose. And this you can do with a thorough history and physical examination. You then do your brainstem function test, which I will discuss in detail, as well as laboratory tests and other ancillary tests, such as an EEG, to help you establish the exact diagnosis of this patient. So when you're presented with a comatose patient, it's good to have an approach in order for you to come up with a diagnosis. A good approach is to check for focal signs. So check, do you have a comatose patient with focal signs? A focal sign, for example, would be hemiplegia. Do you have a comatose patient without focal signs but signs of meningeal irritation? Or do you have a comatose patient without focal signs and no signs of meningeal irritation? For example, if you have a comatose patient with focal signs, you can think if perhaps a vascular lesion, for example, a hemorrhage. Does this patient have an RTA, so had an intracranial or extradural hemorrhage? Or is it in an ischemic event, such as a stroke? If you're thinking of an ischemic event, is it involving the vessel wall, such as a vasculitis? Or is it in the lumen, such as thrombosis or emboli? Are you thinking that if you have focal signs, maybe this patient has a tumor? The tumor can be supratentorial or infratentorial. Remember, the infratentorial region houses the brainstem, and the brainstem we mentioned is where the ascending reticular activation system originates and ensures that we're in a state of consciousness. Then it could also be due to focal infections such as an abscess, neurocysticercosis, perhaps the patient was having a lot of POC, or tuberculoma, we know that we live in a TB endemic area. These patients may have had seizures, maybe it's a known epilepsy patient, and may actually be having a thoughts paralysis. Autoimmune conditions such as acute demyelinating encephalomyelitis, multiple sclerosis, or neuromyelitis optica. If this patient doesn't have any focal signs but has signs of meningeal irritation, which would mean that neck stiffness, Cunning's positive, Rudinsky is positive, but no focal signs, then you think, does this patient have a meningitis, encephalitis, or perhaps a subarachnoid hemorrhage? If you have no focal signs and no meningeal irritation, then you have to think further. What could this patient perhaps have? Maybe the patient has hypoxic ischemia. Was there a cardiopulmonary event, for example, severe pneumonia, and the patient had to be resuscitated? Was there a shock? Was there a near drowning incident? Metabolic conditions are some things that we tend to overlook. And sometimes we diagnose a patient with having a meningoencephalitis when this patient actually has a metabolic condition. For example, urea cycle disorders can cause hyperammonemia, which can alter your state of consciousness, uremic encephalopathy in patients with kidney injury, and organic acidemias, such as your propionic acidemia or glutaric aciduria, which are metabolic conditions that can alter state of consciousness. The etiology of coma in pediatric patients is quite wide and multifactorial. As I've mentioned, it can be infections, inflammatory conditions, vascular conditions, trauma. In pediatric patients, we must think of toxins and drugs. A lot of times in the POPD, we get a child who took perhaps the parent was storing some organophosphate in a soda bottle and the child drank the bottle and the child comes with organophosphate poisoning. Autoimmune conditions. Metabolic, as I mentioned, is something that we tend to overlook. It could be neoplastic, or it could also be due to nutritional deficiencies. So you must think wide and beyond meningitis when you have a comatose patient. So examples of infectious causes that can cause you to be comatose include, they can be bacterial, viral, protozoal, such as cerebral malaria. COVID-19 is something that we're seeing affecting children. Meningitis, which can be due to TB, strep pneumonia, Neisseria meningitidis. It can be an encephalitis, sepsis-associated encephalopathy, focal infections such as abscesses and cerebritis, acute necrotizing encephalopathy. It can be inflammatory or autoimmune conditions. In Kenyatta, we've seen quite a number of patients presenting with ADEM, which is a demyelinating disorder. It can be a vasculitis, such as Kawasaki or Wegener's granulomatosis, collagen vascular disorders. Post-immunization, we have had some patients who received the whole cell pertussis vaccine and come when they're encephalopathic with an altered state of consciousness. We have very many patients in the KNH neurology clinic who have seizure disorders. So if a patient has poorly controlled seizures, they can actually come with epileptic encephalopathy. Sometimes you can have non-convulsive status epilepticus, where the patient doesn't have any motor manifestations, but is actually having electrographic seizures. Hypoxic encephalopathy I've mentioned, such as strangulation, near drowning, shock, hypertension, such as posterior reversible encephalopathy syndrome, and hypertensive encephalopathy. We have a lot of patients in KNH who have nephrotic syndrome and other renal diseases, and they have hypertension. Trauma, we know shaken baby syndrome is something that we commonly see where a parent is frustrated because the child is not sleeping, and you find the parent shakes the child, causing the child to have a subdural hematoma. Road traffic accidents are very common in our setting. Diffuse axonal injury, concussions, contusions. We have many fall from heights. Vascular injuries can be infarctive, cerebral synovenous thrombosis, thromboembolic events, hemorrhages from ruptured aneurysms, subarachnoid bleeds, dissections, which commonly occur, especially in the pediatric adolescents who are into the sports, neoplastic conditions. Remember the neoplastic conditions that involve the infratentorial region, such as your medalloblastoma and epidermoma. These patients tend to come very early in a comatose state, as opposed to those who have a supratentorial lesion, where they tend to come with altered consciousness due to signs of raised intracranial pressure as the tumor continues to grow. Any etiology that causes raised intracranial pressure can cause your patient to be comatose. As I've mentioned, we must do history to see if there's any drug or toxin ingestion. We know a lot of our KNH patients usually go to traditional herbalists. I actually saw one once who came and they came with an altered state of consciousness. Carbon monoxide poisoning. Most of the households use G-codes and they cook indoors, and you can find that the patient comes with altered consciousness. Alcohol intoxication is also common, especially among the teenagers. Some nutritional deficiencies that can cause altered consciousness are like pyridoxine deficiency, folate, vitamin B12 deficiency. Then metabolic conditions. So I gave this slide because it's something that sometimes we tend to overlook. As I said, you must check for fluid and electrolyte disturbances. Hypernatremia, hyponatremia, dehydration can cause altered consciousness. Hypoglycemia, hyperglycemia, such as in your DKA patients. Hyperammonemia, which can result from urea cycle disorders, hepatic encephalopathy. Drugs, for example, in the epilepsy patients, if you overdose them with sodium valproate, then you can actually find that their ammonia levels go up, and usually they end up coming in with an altered state of consciousness. Uremic encephalopathy, mitochondrial disorders, porphyrias, which are metabolic disorders, and any condition with acidosis, such as DKA and your organic acidemias. So when you're presented with this, so bearing this in mind, what do we do when you have a patient who's coming in a comatose state? As I mentioned, you have to do a rapid assessment and stabilization before you take an adequate history. Look at your airway. Usually you open the airway with the head tilt, chin lift maneuver, look into the airway, ensure that your airway is patent. If your airway is at risk, for example, a patient has a declining GCS or a compromised airway, for example, the patient was in a closed room with a GCO and the house caught fire and there's laryngeal edema, then you must intubate this patient early. You then look at your breathing, ensure adequate ventilation to prevent hypercarbia and adequate oxygenation, circulation. Make sure you do early IV access. If you can, put 2 large bore IV needles, take your samples, including your sample for glucose, which can be done bedside, and your laboratory samples, depending on your laboratory samples, in order to establish a diagnosis. If the patient is in circulatory failure, you bolus according to your local guidelines. And if the patient is in decompensated circulatory failure, you need to initiate your inotropes early. Then once you do that, you need to now identify any signs of raised intracranial pressure. So clinically, if the patient has signs of raised intracranial pressure, they would have projectile vomiting, severe headache, blurred vision, altered Glasgow Coma scale. They may have abnormal pupil, pinpoint pupils, anisocoria, dilated pupils. They may have abnormal tone, such as decorticate or decerebrate posturing. They may have Cushing's triad, which is bradycardia, hypertension, abnormal breathing pattern. If you have a fundoscope, quickly look at your eyes, looking for signs of papilledema, and usually you will see the optic disc being blurred. Then you must act immediately if you have signs of raised ECP. Intubate these patients, elevate the head, give your hypertonic saline or mannitol, hyperventilate if you're suspecting impending herniation, ensure you have normothermia, normal glycemia, normal tension, normal carbia, normal oxygen, and early decompressive surgery. So you must liaise with your surgical team if you feel this patient needs to go to theater. Then once you do that, other ways that you can manage your raised ICP is to correct any acid-base imbalances and electrolyte imbalances. Specific antidotes, for example, if you're thinking opiate overdose, you can give your naloxone. Treat seizures because seizures increase the metabolic demand of the brain. Treat any infections early, give your start dose of antibiotic or antiviral agent. Manage agitation because this can increase ICP by sedating your patient. Then now you can take further history once you've done your acute management. Age can be a clue towards the diagnosis. Infants, so if you have a young child like a baby, you'd not be thinking that this child may have swallowed a toxin. You'd think of things like CNS infections, systemic infections with shock, metabolic disorders, especially in the newborn period, where they have an atypical presentation. We suspect abuse, trauma, post-immunization encephalopathy. In an older child, the ones who are walking around and they're curious, then you can suspect ingestion of a toxin, CNS infections, abuse, trauma, DKA, Reye syndrome, which is usually due to aspirin use. In the adolescent child, we know this is the age for alcohol and drug intoxication. They're using their cocaine, they're experimenting, intentional poisoning from attempted suicide, trauma, seizures, CNS infection, DKA, and Reye syndrome. Then you take further history. Then usually if you have sudden onset coma, then you're thinking maybe this is a bleed like a subarachnoid hemorrhage, or perhaps this patient had a convulsion or drugs and toxins. If it's a more gradual onset, you think of infection or a metabolic process. If it's intermittent episodes, meaning that it keeps recurring, you'd think of continuous ingestion of a drug or a toxin. You'd also think of inborn errors of metabolism, which can come with episodic encephalopathy due to a specific metabolic triggers. Recurrent episodes, you think of epilepsy or an inborn error of metabolism. Then you look for associated symptoms. For example, if you're suspecting an infectious disease, if the patient had mumps, they may have parotid swelling. Measles, they may have a rash. TB hypersensitivity, such as erythema nodosum, carditis, arthritis. If they have a headache, vomiting, double vision, you're thinking this patient has raised intracranial pressure. Neck stiffness, meningitis. We have the meningococcal rash. If the patient has hydrocephalus, then they would have a history of an enlarging head circumference, excessive cry, high-pitched cry, irritability. If you're thinking of traumatic brain injury, they may have fractures, subdural bleeds, retinal hemorrhage. In patients you're thinking has seizures, usually you'd suspect epilepsy, space-occupying lesions, or intracranial hemorrhage. For metabolic conditions, they would have failure to thrive, vomiting, peculiar skin, and they would have unusual odors. For example, patients who have tyrosinemia smell like boiled cabbage. Patients who have phenylketonuria will have a mousy or musty odor. Patients who have maple syrup urine disease, the urine will usually smell like maple syrup or burnt sugar. So actually the patient's odor can be a clue towards the diagnosis. Then also, if you're suspecting hepatic encephalopathy, you will see features of jaundice, hepatomegaly, melena stool. If you're thinking uremic encephalopathy, they may have edema, reduced urine output, carbon monoxide poisoning. If there's a history of indoor use of a stove or a jiko, if you're suspecting something like hemolytic uremic syndrome, they may have loose stool, they may have bleeding diaphysis, diabetes. You're thinking if the patient comes in ketoacidosis, and then you also want to take a history. Is this patient immunocompromised? So you need to know the HIV status of the patient, or if they're malnourished, if there's a history of malignancy, family history of TB, migraine, epilepsy, and birth history is also important because it can point to neonatal encephalopathy, such as from birth asphyxia. The breathing pattern is also important. So you must look and see how your patient is breathing, because this can actually give you a clue as to the etiology or where the specific point in the brain is affected. For example, you can have chain-stokes breathing. So in chain-stokes breathing, these patients usually have an alternating pattern of hypopnea followed by apnea. So they would come with, then they pause, then so they breathe quickly and then they pause. They breathe quickly and then they pause. If the patient presents like this, then you think that the lesion could be in the bilateral hemispheres of the diencephalon, which is your thalamus, hypothalamus, epithalamus region. It may indicate transtentorial herniation. Chain-stokes breathing in the neurological patient would be common in patients who have a stroke. It can also occur in congestive cardiac failure, COPD, obstructive sleep apnea, or in uremia. Hyperventilation, usually the patient comes breathing fast. And these patients, usually it can indicate a poor prognosis. Hyperventilation can cause hypocarbia. Usually it would indicate an injury to the pontine or midbrain tegmentum. It can occur due to respiratory failure, fever, sepsis, metabolic disarray, or it can also occur in psychiatric diseases, usually due to conversion disorders. Then we have apneustic breathing, where the patient takes a prolonged pause at the end of inspiration. It usually would indicate a lesion in the lateral tegmentum of the lower half of the pons. We can have what we call cluster breathing, which is periodic respiration that is irregular in frequency and amplitude with variable pauses between clusters of breath. This again would indicate a lesion in your pons. Ataxic breathing is it's usually irregular in both rate and tidal volume, and it suggests damage to your medulla. So this slide emphasizes that it is very important to do a complete physical examination and not just your neurological examination in order to determine the etiology. Of course, there are other breathing patterns such as your deep acidotic breathing that would occur in patients who have DKA. So once you've done that, you now move on to do a full neurological assessment, which includes doing your level of consciousness, your cranial nerves, brainstem function, your motor examination, other neurological signs such as your sensory or cerebellar signs, and then you must look for any impending herniation. So level of consciousness, we know traditionally we use the Glasgow Coma scale. In pediatric patients, you may sometimes have to modify this, especially in the very young patient, because they may not be able to follow instructions. So eye opening is usually rated up to 4, motor response up to 6, and verbal response up to 5. Remember, as a basic reminder, a patient cannot have a GCS of less than 3. So you must do your GCS scale frequently in order to detect any changes, either deterioration or improvement in your patient's level of consciousness. For the very young child, there are other charts that you can use to assess the level of consciousness. Then you need to assess your brainstem function, which I will discuss. So again, brainstem function is important, especially in the countries where it is legal to declare somebody dead if they have brain death. So there are various tests that you can do, including your apnea test, your pupillary light reflex, oculocephalic test or caloric test, oculovestibular test like your Doll's eye reflex, corneal reflex, or your gag and cough reflex. These tests ideally should be done by 2 independent persons. For example, Dr. Kailemia, who's a critical care specialist, can do one test, and then she can later call Dr. Farida, who is a neurologist, to do her own independent assessment. And then once you do that, you can determine if this patient has brainstem death. So the apnea test. So the apnea test is used to determine if your patient has any signs of spontaneous breathing. It must be performed when you're assessing for brainstem death, unless medically contraindicated. For example, if your patient has a suspected cervical spine injury. So usually before you perform your apnea test, you must ensure that your patient has a relatively normal pH. The PCO2 should also be normal. Usually, ideally, your PCO2 should be around 40 millimeters of mercury. This means that you must do your arterial blood gas prior to performing the apnea test. The patient should be normothermic and have normal BP, at least within the 5th percentile for age. You must observe, so when you're performing the apnea test, most of the patients would be on a ventilator. So if you disconnect the patient from the ventilator, you must ensure that you have adequate oxygenation. So when you disconnect, you observe for spontaneous respiratory effort while monitoring your heart rate, your blood pressure, and your oxygen. You then document, so usually it's performed for about 5 to 10 minutes. And once you perform it, then you need to do an arterial blood gas. And when you do your arterial blood gas, you're looking to see if your PCO2 is 20 millimeters above the baseline. So if you had a baseline of perhaps 40 and you do your ABG and your PCO2 is now at 60, and if you have your PCO2 more than 60 millimeters with no respiratory effort during testing, then this proves that your patient has brainstem death. Usually, as I mentioned, it should be performed twice by 2 independent clinicians. Then you do your pupillary light reflex. So the pupillary light reflex, usually the areas tested are your cranial nerve 2 with so your cranial nerve 2 and your cranial nerve 3, which is your oculomotor nerve. So usually you shine a light and then you use your specific pathway. So cranial nerve 2 is your optic nerve. So the light will carry the response through the optic nerve, the optic chiasm. We have some fibers running to the contralateral side, while others run to the ipsilateral side. From the optic chiasm, they go through the optic tract, they pass through the lateral geniculate body, which is in the thalamus, then they go to the pretectal nucleus, which is in the midbrain, and from there they go to the vespal nucleus, which is the nucleus of the oculomotor nerve, and then you have the oculomotor nerve running back into the eye. So usually you need to check and see if you have a response of both eyes, direct and consensual pupillary reflex. And usually abnormalities in any of these reflexes would indicate a problem in the brain. And what problems would this be? If you have pinpoint pupils, it would indicate that you have a possible lesion in your brain. So your eyes would usually appear very small. So the lesion would be in the pons. It can, however, also indicate opioid poisoning. For example, in the ICU, a patient may be on opioids such as morphine and they have pinpoint pupils. It could be due to cholinergic intoxication such as organophosphate poisoning. If your pupils are mid-position, fixed or irregular, then your lesion is likely to be in the midbrain. If your pupils are unilateral, dilated, and fixed, then you think of ankle herniation. In ankle herniation, you have a herniation of a small part of the brain through your tentorium cerebelli, and this can push on the oculomotor nerve, and this can cause dilatation of one pupil. Then if your pupils are bilaterally dilated and fixed, it indicates brain death, drugs such as sympathomimetics, barbiturates, or atropine poisoning. So it's very important to look at your pupils and see if they're reacting, because this can point towards where the lesion is. Then we do the oculocephalic, or what we call the doll's eye reflex. The areas tested are cranial nerve 3, which is your oculomotor, cranial nerve 6, and cranial nerve 8, the midbrain as well as the pons. It should not be performed if your patient has cervical injury. Usually, if you turn your head to the left, your eyes would usually move to the opposite direction, that is the right, in a normal response. So if your eyes remain fixed on a distant position, as if maintaining eye contact, that means that it is normal. In brain death, the eyes move with the patient's head. Therefore, if the head moves to the left, the eyes also move to the left, and that would indicate brain death. Then you also do your corneal reflex. The corneal reflex is tested by closure of the eyelids in response to irritation of the cornea by touching with a sterile cotton applicator. The afferent impulses usually are transmitted by your trigeminal nerve, and the efferent impulses are usually transmitted by your facial nerve. In an intact patient, the touch results in closure of the eyelids and the eye may rotate upwards. If you have brain death, you will have no response to your corneal reflex. Then you also do your oculovestibular reflex, which is the caloric test. Many of us are familiar with this. So the area tested are your cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 8. Your oculomotor, abducens, trochlea, and vestibulocochlear nerve, as well as your pons and your midbrain. In brain death, there will be absence of eye movement. So how do you perform your oculovestibular test? So you either use cold water or warm water. So if you take so usually the patient should be lying flat, should be lying elevated at 30 degrees. You should ensure that the patient has no cervical injury. You should quickly look into the ears to ensure that there's no impacted wax, which can influence your test. You then take cold water into a syringe and you inject it into the ear. So for example, in this patient, if you inject cold water into the left ear, then usually you want to look at the first face. So if you inject cold water, the eyes will quickly move to the opposite side in a normal response. If you inject warm water, the eyes move to the same side. So The mnemonic we use is usually COWS, cold, opposite, warm, same. In brain death, there will be no movement of the eyes when you perform your caloric test. The gag and the cough reflex is important. We've all choked on something, and we know when something goes to the back of your throat, it causes you to gag. So usually in brain death, if you put a spatula at the back of the throat, there will be absence of both cough and the gag reflex, which is suggestive of brain death. Then once you've done your brainstem tests, you need to move on to your motor examination. So usually decorticate and decerebrate posturing would indicate that you have severe brain damage. So in decorticate posturing, you have flexion of your upper limbs, and in decerebrate posturing, you have extension of your upper limbs. Other neurological findings that must be done, you must take your ophthalmoscope and do fundoscopy. Look at your eyes for features of papilloedema, retinal hemorrhages. Look for signs of meningeal irritation, which you said are your Canning side, your Brudzinski sign. Look for neck stiffness. Cranial nerve examination is very important. So you must do your 12 cranial nerves: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, spinal accessory, hypoglossal. Majority of the nuclei usually arise in the brainstem, and therefore most of the time in brainstem death, you may find that you have some cranial nerve pulses. Herniation syndromes are very important. They tell us that there's raised intracranial pressure. They're an emergency because if not treated, they can lead to early death. So the brain tissue usually moves from higher to low pressure areas when there is asymmetrical, unilateral, or generalized increase in intracranial pressure. So there are various ways in which you can have herniation. It can be subfalcine, transcalvarium, central or tentorial, ankle, which I had mentioned, or it can be downward cerebellar, tonsillar. And sometimes you can actually have the cerebellar herniating upwards. Other systems must also be examined. As I said, we mentioned about the respiratory system and the breathing patterns. Check for any signs of lung disease. You know, lung disease can give you hypoxia, which can alter your level of consciousness. Do a full cardiac exam. In the pediatric patient, you're looking for any congenital or acquired heart diseases. We know things like infective endocarditis can predispose you to thromboembolic events. You can throw an emboli which goes into the brain, causing altered consciousness. You want to check for any arrhythmias or murmurs. Abdominal examination, look for any hepatosplenomegaly, which would point towards hepatitis, sepsis, malaria, any palpable abdominal masses, which can point towards things like intussusception and encephalopathy. Then once you've done your history, your physical examination, now you can move on to examination, to your investigations. Neuroimaging is very important. It's urgent in order to identify treatable causes. CT scan is more available in our setting, usually than the MRI. So most of the times you'll find our patients will be done for the CT scan first. It is especially important in identifying hemorrhages because it allows it, usually if you have an hemorrhage, it will appear hyper intense on the CT scan. It can also identify structural lesions or clinical, or when your clinical diagnosis is evasive, meaning you're not quite sure what your patient has. It's usually done, however, after stabilization of a patient. And as I mentioned, it's often faster to obtain than the MRI of the brain. The MRI of the brain, however, is still useful. And even if you've done your CT scan, you must still do an MRI of the brain. So CT scan, apart from telling you about hemorrhages, would also tell you if you have calcification. MRI brain is good for telling you if you have any structural brain abnormalities. You must do all your sequences for your MRI, your T1, your T2, your ADC and DWI, which should be good for telling you if you have edema. We can also do your MRAs, MRVs, if you're suspecting cerebrosynovenous thrombosis, if you're suspecting a vasculitis or focal cerebral arteritis, or any problems with your arterial vasculature. MRI can point towards specific diagnosis like multiple sclerosis, acute demyelinating encephalomyelopathy, because you see specific changes on the MRI. Then, based on your history and physical examination, you will then determine what further testing that you need to do. If you're suspecting toxins, then you can do your urine toxicology screen. If you're suspecting a CNS infection, you can do your CSF studies. If you're suspecting a metabolic derangement, you can do your ammonia, your lactate, your urine for organic acids, your plasma for amino acids. If you're suspecting hypoglycemia, DKA, you can do your sugars, uremic encephalopathy, you can do your UECs, hepatic encephalopathy, you can do your liver function tests, you can do your thyroid function test if you're suspecting Hashimoto's encephalitis. So basically, most of the other lab tests will be guided by your history and your physical examination. Ancillary neurological diagnostic studies can also be done. These are not required to establish a diagnosis of brain death and are not a substitute for neurological examination. EEG can point toward a specific diagnosis. However, remember that you must look at the clinical context when you do your EEG. For example, if you have a patient in ICU who's on sedatives, many of these sedatives, such as your phenobab, your phenytoin, your midazolam, can actually alter your EEG results. You may actually find burst suppression or slowing of your waveforms, which may interfere with interpretation. Epileptiform discharges can point towards non-convulsive status epilepticus. Cerebral angiography, if you're thinking of problems with your arterial system, you can also do other ancillary tests like your transcranial Doppler ultrasound. So management, of course, will depend on the etiology. However, as I mentioned, you must do your initial rapid assessment, which is your ABC approach. Treat any correctable causes, such as your acid-base imbalances, your hypoglycemia, your hyponatremia. You must treat your raised intracranial pressure with the methods that we talked about. Treat sepsis, manage your seizures according to your local guidelines. You then look for specific treatment in some cases. For example, DKA. We know DKA, if you overhydrate, you can actually worsen the level of consciousness of these patients by causing cerebral edema. If you're suspecting cerebral malaria or organophosphate poisoning, then you can atropinize. A thorough history and examination can actually help you arrive at a diagnosis. So there's more beyond diagnosing all patients with meningitis and encephalitis. And counseling is important for if you're suspecting brain death and other disorders of consciousness which carry a poor prognosis. So this is just a summary of how you should manage your patient. So emergency management, once you do that, you do a thorough history, thorough physical examination. As I said, it's not just a neurological examination, but you must examine all systems in order to arrive at a specific diagnosis. Then you do your neuroimaging and other ancillary tests to help you arrive at a diagnosis. If you have treatable conditions, initiate the treatment immediately. Otherwise, offer supportive care, and you must counsel the patient on the long-term outcome of the patient. Prognosis depends primarily on the cause. Coma from drug intoxication and metabolic causes usually carry the best prognosis. However, you as a clinician must be able to identify that it's actually a drug intoxication or a metabolic cause. Prolonged coma after global hypoxic ischemia usually carries a poor prognosis. Infectious encephalopathies have a good outcome with mild or moderate difficulties only. So usually the viral causes of altered levels of consciousness carry a better prognosis than the bacterial causes. But we have vaccines that can help prevent that. Children who survive traumatic injury usually have a better prognosis than children who suffer from global hypoxic ischemia. So these are my references, and I'm now open to questions.
Thank you so much, Dr. Lucia, for a very elaborate, informative, and interesting presentation. There are a few questions in the Q&A box. I'll also give time to others to put in their questions. So I'll start with a question from Elvis. Could you comment on blood pressure, ABGs, and oxygen therapy in ICP management in pediatrics?
So please repeat that, blood pressure.
So blood pressure, ABG, arterial blood gas, and oxygen therapy in ICP management in pediatrics?
Okay, so these are all very important, beginning because they can affect the intracranial pressure in the brain. So the brain usually requires oxygen because and oxygen is usually carried by the blood vessels. So you have to ensure that you do not have hypoxia, because hypoxia can increase the metabolic demand of the brain and thereby increase the intracranial pressure of the brain. When it comes to your carbon dioxide levels, you want to ensure that you have normal carbia, because if you have hypercarbia, which is increased CO2 levels, it can cause vasodilation, and vasodilation can again increase the intracranial pressure in the brain. You also want to ensure that you do not have hypocarbia, because hypocarbia can cause vasoconstriction, and vasoconstriction will reduce the blood flow to the brain, thereby worsening the intracranial pressure in the brain. You also want to ensure that your patient has relatively normal blood pressures. You don't want to have your patient having hypertension or hypotension. Again, we know that if you have severe hypotension, this can interfere with the cerebral autoregulatory mechanisms of the brain, thereby reducing blood flow to the brain. And hypertension can also worsen the outcome of the brain. So as I mentioned, you want to ensure that you have normal glucose, normal oxygen, normal PCO2s, normal glycemia, normal tension, and normal blood pressure.
Thank you for that response. The next question is from Kaburia. In case of organophosphate poisoning, is gastric lavage indicated in children?
So organophosphate poisoning is usually treated by atropinizing the patient, and that is the appropriate treatment.
If there's anyone who has any other question, you can type it out. But I think those are the two questions that I can see so far. Maybe Dr. Lucia, you could give us a take-home message.
Okay, before I give the
sorry to interrupt. There
Yes.
are a few other questions. Maybe you, Dr. Kalemi, you weren't able to see because that point you dropped off, but the three other questions from our attendees. If I could just go through them.
Okay.
Yes, please, Nelson, thanks.
Yes, Anthony Kiunga is asking, what's the maximum dose of treating trauma seizures using both phenytoin injection and phenobarbital injection in an emergency state while still managing oxygen efficiency?
Okay, so ideally, when you have a patient who presents with seizures, your aim is to abort the seizures, and usually it depends on the local guidelines. We have our basic pediatric protocol, which usually guides us on how to abort the seizures. So if you have your patient who you have given either you've given your phenytoin injection and you've proceeded, patient is, so usually you can have status epilepticus usually occurs if you have uncontrolled seizures. So you can have impending seizures, you can have established status epilepticus, you can have refractory status epilepticus or super refractory status epilepticus. So usually you use your local guidelines. Usually in our setting, you can start with your phenobarb. If the patient is still having your seizures, you can give your phenytoin or phenytoin. There are many other agents that are now available. Usually in our setting, we can actually repeat the loading dose of phenytoin or phosphatic phenytoin. Agents like levetiracetam, which is Keppra, have now come up. You can give that dose. If your patient is still having seizures, then now you need to be thinking of managing this patient in the ICU setting under Dr. Kailemia. So this patient should be intubated, and then you can start the patient on a midazolam infusion. If the patient is still having seizures, then you can think of adding further medications, but you must bear in mind the diagnosis of the patient. For example, You wouldn't use ketamine because it can further worsen intracranial pressure. You need to think of your other agents like your thiopental, and basically you need to knock this patient off completely until you're able to abort the seizure. So you'd keep going until you're able to abort the seizures. Usually if you've given your loading doses and the patient is still having seizures, then this patient needs to have an infusion. And remember, drugs like your midazolam, you can actually keep going up on the infusion until you're able to abort the seizures.
All right, thank you. The next question is by Lando Elvis. He's asking, in raised ICP management, apart from mannitol, can you use hypertonic saline?
The answer is yes. Remember, mannitol, you would not use it if you have a patient who has compromised kidney function, because mannitol can interfere with your kidney functions. And if you do use it, you must constantly monitor your UECs. So yes, you can use hypertonic saline. Remember, these are osmolar agents, so they're aiming to reduce the intracranial pressure within the brain. So the answer is yes.
All right, and then the third question is from an anonymous attendee. Which drugs would you recommend to maintain normotension in a patient without increased ICP?
So which drugs would you use to maintain normotension? So that depends on how your patient is. So usually if your patient is hypotensive, then you would need to give your inotropes to ensure that you enable the BPs to normalize. If your patient is hypertensive, then you need to think of your antihypertensive agents like your amlodipine and your hydralazine. I don't know if Dr. Kaileme, you want to add anything on that?
Just what you've said, if a patient has got low blood pressure and you want to maintain pressures to be able to allow for cerebral perfusion, you would give adrenaline or noradrenaline. Those are the main two inotropic drugs that we give. Yes. So it's the same thing, no addition. And also, as you're giving, depending, some patients have, if it is a TBI, if there's blood loss, then you want to also replace fluids. That will help with your blood pressure.
All right, those are, I think, are the questions from before. I don't know whether you can see the other questions which just came in while we were addressing these other ones, Dr. Kaileme.
Yes,
yeah, I can see them. I'll continue.
All right,
All right.
So there's a question asking about permissive hypercarbia in patients with raised intracranial pressure. Again, this one I'll let Dr. Kaileme answer because she sees a lot of these patients in the ICU setting.
Okay, so the permissive hypercarbia is not, I think what you meant to ask is hypocarbia maybe. So you're not supposed to have high CO2 levels. As had been mentioned, this tends to lead to vasodilation, and vasodilation will increase your cerebral blood flow and therefore worsen the cerebral edema. So there's actually no option for permissive hypercarbia, that is high CO2. In terms of lower CO2 levels, again, in the recent studies, it is not recommended to have lower CO2 levels because this again can predispose the patient to reduced flow and cerebral ischemia, which worsens the brain injury. So as mentioned, normocarbia is what is recommended in some instances when you have acute herniation and the patient is on their way to surgery. In some cases, it is recommended. So this is more like a tier 3 management to hyperventilate the patient. So this is tier 3. So it's not a common thing that's normally done. It's on the tier 3 management, and this is for a patient who you suspect is having acute herniation and they're on their way to surgery. So the main thing when you're managing this patient is to make sure that their CO2 levels are within normal. That is the recommendation.
Okay. And then I think There's also a question about how you use the hypertonic saline and mannitol in a patient with raised ICP. I think we've mentioned. So usually you give a bolus of around 2 to 5 mL per kg of the hypertonic saline. You can give it as an IV bolus. And yes, and then there's also a question on how we treat a baby with pyridoxine responsive seizures, but treatment is withdrawn partly. So most of the time for pyridoxine responsive seizures, this would occur in the neonatal period where you've given your patient, you have a patient perhaps who's having convulsions and they don't seem to be responding to the anticonvulsive medication. Then you can give a trial of pyridoxine and see if there's a response to this. If there is a response to this, then that would point you towards possibly having pyridoxine responsive seizures. Unfortunately, in our setting, most of the time we do not have the genetic ability to confirm the diagnosis of pyridoxine responsive seizures. So this would usually be a clinical response that you look for if your patient has not responded to the anti-seizure medication that you have locally available. So there's also a question about, you mentioned sedation to prevent agitation in impaired consciousness with activated mental states. Are we worried about depressing the level of consciousness with resultant alteration in the presentation, hence clouding the actual mental status? No, in this case, no, because this patient has impaired consciousness. And if the patient is agitated and then you would not want to, and the patient has signs of raised intracranial pressure, then you would actually need to sedate this patient, because leaving the patient in an agitated state can actually worsen the outcome of the patient. But of course, this is usually a multidisciplinary approach. So you have to be sure of the diagnosis that you have in your patient, doing thorough history examination, and then give the appropriate medication. Because as I mentioned, you need to be careful on the choice of sedative that you use in your patient, because you want a assessment. But it is true, the drugs that you give would usually can alter the consciousness. And that's why we said if you're suspecting something like brainstem death, you must wean off the patient all medication before you make that diagnosis.
There's one more question. In stroke patients, should the BP be reduced to normal or low hypertensive? I guess lower end of the hypertension.
So in stroke patients, ideally they should, the BP should be within normal for age. It should not be reduced to the lower end of the level. It should be within normal for age. Usually we aim for around the 50th centile.
Yeah, I think the last question is from Joyce. What would be the management of delirium in an ICU patient, in an ICU patient, an ICU pediatric patient?
I think Dr. Kelemia, that one is for you. But usually you need to know the cause of the delirium, which was, delirium, of course, would be a disorder of consciousness. So again, if you're managing this patient, you need to know, why is this patient having delirium? Is it, and this again, you get from doing a good history, is it something that the patient may have ingested? Or is this, remember, we get a lot of agitated patients, even the patients who have uremic encephalopathy, they can get delirious. So only with a proper history and physical examination can you be able to clinch the diagnosis and know why the patient is like that. And once you know the reason, then you can institute the appropriate management.
Maybe to add on, in our case, where we'll be dealing with it is patients who are sometimes having withdrawal symptoms. For a patient who's already been on sedative, sometimes they tend to present with delirium, and for that, we would, once we are withdrawing, and that's if we withdraw at a faster rate than we should. So what happens is that we reinstate the drugs. Most of the time, it's associated with opioid withdrawal. So we reinstate if it is morphine at half the dose, and then we taper off. So that's how we'd manage for withdrawal symptoms. Delirium as one of the withdrawal symptoms. I think we will end there. Maybe Dr. Lucia, you can give us some take-home messages before we close this session.
Okay, so what I'd like to emphasize is when you're in the pediatric outpatient department and you have a child presenting to you with an altered level of consciousness, remember, number one, what you need to do is manage the acute problems that the child has using your ABCDE approach. Once the patient is out of the acute phase, you now take a very detailed history and physical examination so that you can try and establish why this patient is having an altered state of consciousness. So with history and physical examination, most of the time you'll be able to note the exact site of the lesion in the brain. And then once you do that, the next other important thing would be now your neuroimaging. Try and do what you can access quickly. I know sometimes in KNH we have delays. So if you have early access to CT scan, do your CT scan, do your neuroimaging, and then the other lab tests that you do will be guided on based on your what history you've obtained from the patient, as it will tell you what tests that you need to do, because as we've seen, there are so many investigations that you can do to arrive at a specific diagnosis. Then once you have the diagnosis, if you have a treatable cause, treat it early. And if you don't have a treatable cause, you must ensure that you give adequate counseling to the patients and the parents about the long-term outcome of this patient, because a lot of the patients who are comatose or vegetative, then usually they would need the parents would usually need counseling so that they can know the long-term outcome of the patient. Thank you.
Great, thank you so much again for taking time off to give us this very informative lecture. It was well presented, and I think we've all learned quite a bit from it. I think I'll end the session here. Nelson, unless you have any updates.
Yeah, just to mention, I've seen there were a few questions asking for the slides and for the recording of this webinar. So this webinar will be uploaded to the KNH website and also to our YouTube channel, which is KNH Research on YouTube. And that will be by Friday, so you can always visit and recap on what Dr. has covered today. And that is all.
Right, thank you.
Thank you.